repeat the welcome to our supporters and others who are joining us this evening. As Suzanne mentioned, we have the lecture coming up and the question and answer session, which are the real guts of why we have these meetings. This is the second virtual meeting we've had because of COVID, and we hope next year maybe we'll be able to meet in person. Just a few background notes. As you probably all know, unless you're new to us, GRSC is a registered charity. It raises money, issues official tax receipts to donors, and uses this money to make research grants. Its audited statements, or its financial statements, are audited. Our treasurer, Tom Gottlieb, will speak about that more in a few minutes. We have a board of 12 directors who have diverse backgrounds. Under the bylaws, the directors serve on a rotating basis for 3-year terms. Recently, we elected 4 directors for 3 years. The others will serve out their terms. So I'm going to bring up the slides in a minute, but I'll just comment that in addition to the information you'll see on the slides, there's a lot more information available on our website, and not only about the directors, but about the society in general. So if I could just have the slides up, please, Suzanne. That's moi, about which I need not say anything else. I'm a director and president, have been for a number of years. If we can have the next one, please. Martin Chasen is our past president. And as I mentioned, you can see a brief description of what these people do. And I don't want to go into that with a view to trying to expedite things. So next, please. Renee Wolf is our vice president. Next, please. Tom Gottlieb, who you will hear from more later, is our treasurer. Next, please. Dr. Mark Schaffer is our executive secretary and is highly involved in our participation in the Scotia Marathon, about which you'll hear more from Tom a bit later. Next, please. Dr. Trope, I think, is known to everybody. He's the founder of the society and the head of our scientific advisory committee, about which a few more comments will be made later as well. Next, please. Dr. Catherine Burt, the vice chair of our scientific advisory committee. Next, please. Dr. Raj Bendlish, who, as you'll hear later from Tom, has recently been involved in putting on a webinar and is very active on the board. Next, please. Dr. Hutnick, a relatively recent appointment, and we, those who've been on the board for quite a while, welcome her. Next, please. Alf Quinter, who's also a recent appointment to the board, and we also welcome him. Next, please. Scott Leslie, the third of the recent appointments to fill the full slate of 12. And he's the last to join just recently, and we welcome him as well. Next, please. Stuart Murray, who's been on the board for quite a while with an accounting background and has been very helpful, particularly with our website design and some of the other IT things. Next, please. And Suzanne, who's not a director, but is our capable administrator, keeps us all on the straight and narrow and looks after all of the stuff that the directors themselves probably aren't able to deal with, or are better leaving it to her. Unfortunately, during the year, we lost 2 directors. One was Mel Mitzel, who passed away sadly in February after a long illness. Mel had been a really valuable contributor. And Dr. Blair Fearon, who'd been on the board for quite a while, resigned or retired from the board in May. So in order to recognize Mel's contribution, the board has established the Mel Mitchell Research Excellence Award. And in addition to the recognition, The recipient also receives $5,000 on top of the amount that's granted otherwise in accordance with the application that's been approved. The recipients this year are Dr. Yaping Jin and Dr. Yvonne Buys for the highest ranked original new project that was accepted this year. So that's the inaugural award, and we certainly plan to carry on with that in the future. So congratulations to both of them. Promoting awareness about glaucoma and raising money for research grants is the prime objective of the society, as I think those of you who are familiar with this know. There's a process for reviewing applications from researchers through the Scientific Advisory Committee headed by Dr. Trope and Dr. Burt. That results in recommendations of successful applicants, and the board finally approves those and recommends the grants. Tom will say more about that shortly, in addition to talking about the financial statements for the year ended May 31 and the current financial situation. The audited statements were approved by the board recently and have been filed with Corporations Canada as required under the governing law. Tom will also mention the upcoming Scotia Marathon and talk more generally about some of our operational things. He will then turn things over to Dr. Trope, who will introduce our lecturer, Dr. Sogbesan. Then after that, we will have the question and answer period that is always very popular. But just before I turn things over to Tom, I'd like to present certificates of appreciation to several supporters and others. This follows the practice we've had in the past at previous meetings. So we're going to put up certificates for the recipients with a brief description of who it is and what it's for. First, Dr. Jin, as I mentioned, was one of the recipients of the inaugural Mel Mitchell Award, and this is in recognition of that. Next is our own Tom Gottlieb, the Treasurer, in recognition of his valuable contribution as Treasurer and for keeping us on the straight and narrow in that regard. Next, Don Johnson, who's been a very loyal, generous supporter financially for many, many years. And that is much appreciated. And we can never say too many thanks to Don for his ongoing support. Next, please. Jeremy Smith, another significant contributor this year. And we would like to recognize him as well with this certificate. So thank you very much. Next, please. Isabel Beaton for her generous financial contribution on her own behalf and on behalf of members of her family who were also loyal supporters over the years. And I think that's the end of my contribution to this. I will turn at the end to wrap things up, but now I will hand things off to Tom.
Okay. Thank you very much, Jim. So my name is Tom Gottlieb, and as Jim said, I'm the treasurer for the society. It's hard to believe it's my 4th year as treasurer. Seems like time flies when you're having fun. So Suzanne, if you could put up the first slide, please. Thank you. So let me start by thanking you for joining tonight, and I'll go over some of the financial highlights for the year. First of all, the fiscal year for the society runs from June the 1st until May 31st each year. So after the year end, our fiscal year end, our auditors come in and audit our books around July and August, and we get our final financial statements presented to the board of directors at our September board meeting. Those financial statements were approved by the board, and they will be posted on our website. If they're not there already, you can go to www.glaucomaresearch.ca and take a look at our financial statements if you'd like. We're very proud of the fact that over 80% of the money that's donated to the Society goes directly to fund research projects. We have a very, very low overhead, and almost all of the money that is donated goes directly to fund glaucoma research in Canada. We're very proud of that. As treasurer, it's my job to count all the money that comes in and watch like a hawk all the money that goes out. So you can see from this slide, we generate revenue from various sources. First of all, we really appreciate all the funds that are donated by supporters and donors like you, who come to appreciate the information that is provided from the Society. You can go to our website and make donations. You can send in checks. I'd like to point out that, no, I'll mention that something later about our website. So many members like Isabel Beaton and Jeremy Smith, they make donations to honor life events like birthdays or anniversaries, and it all helps the Society very much. We produce 3 mailings a year: a fall newsletter, a holiday card, just to remind you that we're still here, and a spring newsletter. We will not inundate you with mailings and emails and special offers. We won't make you feel guilty because we didn't meet our arbitrary goals and quotas in any given period. We will never send you cheap ballpoint pens or calendars or Post-it notes, but we will send you these 2 newsletters a year, and hopefully it will provide you with some information about the research projects that are being undertaken, and some of the events like our webinars and supporters meetings that we schedule every year. We also receive money from bequests from donors who have passed away and have been kind enough to remember us in their will. And for that, we are very, very grateful. It makes a huge difference in our ability to fund research projects in any given year. And I can remind you that we also accept stocks and bonds. So if you have a marketable securities in the form of stocks, for instance, you can donate and save the capital gains tax, and we benefit from the current value of the security. Every year we participate in the Scotiabank run. This year it's coming up on October 24th. If you go to our website, you'll be able to sponsor participants in the run, and I have a little bit more to say about that later. I'm pleased to say that we had a very good year last year. We did award 13 research grants and the very first Mel Mitzel Research Excellence Award, which Jim mentioned, which is an additional $5,000 grant. And our total awards this year were just over $256,000, which was very good. Last year, we didn't have such a great year. We only awarded 9 research grants because of the funds that were available, and we distributed $180,000 in 2020. So next slide, please, Suzanne. So operationally, we also we're busy all year round. This year was the first year we launched our webinar series on a general topic of demystifying glaucoma. The first was given by Dr. Bindlish on eye drops, and the second was offered by Dr. Burt on glaucoma testing procedures. Both of these were very well received. We received all kinds of questions about them. I think for the first webinar, the very first one, we had just over 100 participants. The second one was even more popular with about 180 attendees watching that. Those webinars are available on our website, and we are planning to schedule 2 more webinars this year on various surgical procedures involving glaucoma and other things. So stay tuned for those. We also put quite a bit of effort. Stuart Murray, one of our directors, and Suzanne Marshall put in a number of improvements to our web research portal. Most of you probably are not even aware that we have a research portal. It's not the public site. It's a separate website where researchers and scientists who wish to submit proposals to fund research, they submit their proposals online on our research portal. Suzanne receives the proposals and distributes them to our peer group of evaluators who score them for relevance and importance in the field of glaucoma. The scoring is then collected online, and it's then our scientific advisory committee headed by Dr. Trope and with the help of Dr. Burt and others, review all of the proposals and make the recommendations for award. Then I get to say how much money we can spend on awards each and every year. We're ready to start the research cycle again in a couple of weeks. We'll open the portal for research proposals to be submitted, and then we will go through that process using our improved research portal. We also did quite a bit of work to improve operations in the office. We upgraded our computer infrastructure. All of our systems are backed up and running from the cloud now. Because we had to get used to the challenges of COVID, we now have the ability to work from anywhere, and which has made a big difference. And things are running like clockwork right now, thanks to, again, to our administrator. Okay, next slide, please. So I mentioned before, the Scotiabank, they called it the Waterfront Marathon because it used to run along Front Street and along the waterfront. Now with COVID, a lot of the race is virtual, meaning you can basically participate by running or walking anywhere you want in your neighborhood. But it is a big fundraiser for us. Each year we raise from $50,000 to $60,000. We've already raised about $46,000 to date. If you'd like to see what's going on, you just go to our website, glaucomaresearch.ca, and right at the top of the lead homepage, you'll find a link where you can go to see who's participating in the run, and you can sponsor any one of the members of the board who are running or others. We're happy to welcome Aqueous Pharmaceuticals, the company that provides eye care products, and their team of 5 or 6 staff have joined us last year for the first time, and this year again to participate in the run. So you can look out for that. Next slide. So there's an old cliche, it takes a village. We can't do everything we do just by the skills of our board of directors, who all work on a volunteer basis. And Jim mentioned we've welcomed 3 new directors to the board this year. And we have a highly skilled team of professionals. We cover the medical profession with ophthalmologists, of course, and medical general practitioners. We also have a few accountants, a couple of lawyers, and 1 lone professional engineer, that's me. So we have quite a good diversity of skills, and it all seems to be running quite well. But there are others who generally work in the background who don't get a lot of thanks, and I wanted to point out the people, were about 40 qualified scientists, researchers, and hospital workers who review the research proposals that we receive and submit the scores. And without them, we couldn't possibly make sure that we keep the high quality of research in the field of glaucoma in Canada ongoing. So thank you to them. Wanted to mention for our content contributor, Dr. Jason Kwok, who works with Dr. Hutnick, or did work with Dr. Hutnick, and who helped us by reviewing the hundreds and hundreds of questions and answers that we publish on our website. Dr. Vindlish is our Q&A guy. He provides answers to all your questions that come in. And they just got a little out of control. They were a lot of duplicates. They were a little bit disorganized. Some were a bit out of date. So Dr. Kwok reviewed all of them and provided an edit of those. So our Q&As will be much better organized. And if you have a question about glaucoma, you can probably find the answer on our website. I'd like to shout out to Mr. Jordan Stevens. It's not well known that you can go to our website, and if you don't want to just make a donation once in a while, you can sign up for monthly donations. And Mr. Stevens is one of our highest monthly donors. So when you do that, you subscribe on our website. Whatever you decide will be taken from your credit card and donated to the society on a monthly basis. It allows us to know in advance what funds are coming in, because it's a regular monthly donation, and it's very much appreciated. I'd also point out that on our website, you can make a donation in honor of a birthday or an anniversary, or if you have to in memory of someone, and you can honor that person by making a donation on our website, choosing an electronic card notice to be sent to the person, which will tell them that you've made a donation to the society in their honor. I mentioned the Scotiabank Marathon. I have to always shout out Patty and Kevin Birch. They're not directors. They're just people who are like the society. They've been touched by glaucoma, and they feel that they want to make a difference. And they run with us every year and raise money in the Scotiabank Marathon, which we appreciate. And also Aqueous Pharmaceuticals, who for the second year sent us a team of staff, and they run both here in Toronto, and some of their people in Vancouver are participating in it's really a walk on October 24th. We also, for the first time, I'd like to mention Dr. Armstrong, who for the first time, we've been wanting for a long time to get pamphlets out into pharmacies and doctors' offices, and we have a pilot program that Dr. Armstrong has volunteered to lead, to get the word out about the society, and we think that's going to be very helpful. And always, I want to thank our corporate sponsors, Santen Canada, who are in the eye care business and provide medical devices, surgical devices for eye care. And they are sponsoring this supporters meeting and our meeting last year to offset the cost of producing the meetings. And Allergan also, who provide eye care products and eye drops mostly, and some surgical equipment for eye surgery. Allergan sponsored both our webinars last year, and we appreciate that very, very much. So with that, I'm done. Thank you for listening. I'm going to turn the floor over to Dr. Trope, and he will introduce our guest speaker.
Thank you very much, Tom. It really gives me great pleasure to introduce the 11th Albert Waxer Lecture this evening. I have been asked who's Al Waxer. Al was the second president of this organization, and he was on the board for 20 years plus. This series of lectures honors his legacy at the Glaucoma Research Society of Canada. Tonight's Albert Waxer Lecture is going to be given by Dr. Enitan Sogbesan. Enitan has had a very interesting career to date. Enitan has been educated on 3 continents. He obtained his basic medical degree in Lagos, Nigeria. He then went to the United Kingdom, where he has not 1, but 2 Masters of Science degrees, both in ophthalmology, one in community ophthalmology and one in advanced ophthalmology. He then decided that he wanted to come to North America, and he joined the residency program at the Ottawa Eye Institute, where he trained to be an eye physician and surgeon, finishing up with his fellowship from the Royal College of Surgeons of Canada. If that wasn't enough, he decided he wanted to become a glaucoma specialist. So he went to the University of Alberta, where he did further training. He was snapped up by McMaster University, where he is currently an associate professor in that department of ophthalmology. Enitan has a great interest in education. He is the residency program director at McMaster, which means that he sets and trains and evaluates the young ophthalmologists of tomorrow in Hamilton. His research is also in education. So without further ado, I'm going to hand over to Enitan because he's going to talk to us tonight about his research activities, specifically creating a virtual reality app for patient education, treatment adherence, and quality of life. Dr. Sogbesan, thank you.
Thanks, Graham, for the generous introduction. I also want to thank the Glaucoma Research Society for giving me this opportunity to be part of this discussion today. I'm just going to share my screen. So today, I'm going to be talking about virtual reality and glaucoma, and how do we improve patient education, adherence, and compliance. So this work is, so today the objectives of our discussion today will be to discuss the activity and functional limitations that glaucoma patients experience. We'll also discuss about the glaucoma treatment and adherence, and how we can use virtual reality to optimize care, improve adherence, and then the quality of care. I'm also going to provide you with an overview of the recent support from the Glaucoma Research Society for our study. What do we know about glaucoma? We do know that glaucoma is an irreversible cause of blindness worldwide, and that the prevalence of it is increasing. It's forecasted that about 112 million will be affected by 2040. When we take all of these social limitations and the effects of the morbidity into consideration, we do see that glaucoma poses considerable socioeconomic burden globally. And the only way we can sort of dial this back is by making sure that we diagnose the disease and manage it in the long term. Also, what we do know is that 50% of those who have glaucoma don't know it. A previous study by Dr. Traub and Dr. Byers shows us that over 60% of people that are presenting first time in the eye clinic usually have moderate to advanced glaucoma. There are certain risk factors that are there. We look at some genetic factors, we look at some vascular risk factors, which are listed on the right side of the screen. Aging in itself is a factor. And we do at most times try to address some of these factors. Putting it all of this together, everybody do have their glaucoma stories. When we look at people, different people, and they have their stories, but I do not think that that story should end too soon. And that's why we talk about how do we make other people aware of glaucoma, and how do we reduce the burden of glaucoma disease. Some of the stories starts with what the symptoms are. So there are a lot of symptoms that deals with how it affects the daily life every day. It also affects the limitations that we see in most people with glaucoma. The increasing difficulty with the task, the impact of that on their driving and their daily lives, and the effect of that also on their quality of life. And that's impairment goes with increasing visual field defects. So we're talking about from the early stages, it may affect reading, task, mobility, and eventually driving. and most people do have to give up driving afterwards. It's also been shown that most glaucoma patients do fall a lot. So 3 times more likely to have fallen in the previous years, and about 6 times more likely to have been involved in a fault accident. What's common in all of this is the impaired useful field of vision that our patients with glaucoma does have. And in addition to that, we do know that that's change in terms of accidents and collisions are related to the fact that people with glaucoma cannot really process things quite quickly as other people without glaucoma. Also, the compensatory mechanisms that tends to happen do not happen in patients with glaucoma, and therefore more likely to fall. A model has been developed that we can actually estimate the number of people who have the risk of falling when we put all of the different parameters together. We also know that when you have all of this, although the eye tries to compensate for the visual field changes that we see in glaucoma, however, the pattern in glaucoma makes it difficult when we have to negotiate obstacles, and therefore there's an increased likelihood of collisions that does take place. However, we do have high functioning glaucoma patients who over time have been able to develop these compensatory gaze mechanisms, which has helped them in terms of performing their everyday lives. So this system of high tracking have the potential to assist some of our glaucoma patients to improve their performance on their everyday tasks and enhance their long-term quality of life. In our clinics and in our studies, most of the things that we do, we look at the clinical parameters for functional visual ability, and we talked about visual acuity, we talked about visual fields, contrast sensitivity, and we've also used questionnaires that have been validated and used over time. All of this has provided us with some kind of information. However, what we do know is that these tests do have some limitations in terms that they're not reflecting real world life situations for our glaucoma patients. There are certain factors like recall bias, personality, psychological factors that does affect those things. Even the fact that some of our patients have rheumatoid arthritis or other neuromuscular morbidities that do affect them. And also some of these tests require a bigger space for us to be able to determine this. However, with the advancing technology, that has helped us in terms of we can now use virtual reality and objective simulation of these functional abilities to actually determine things much more quickly. And these virtual reality technologies actually bring you and make you to give you a sense of you being there yourself. So it gives you that in the limited space that you have, but they do give you a more magnified image of what you want to do. In glaucoma, we've used virtual reality to assess our visual function and performance. We've used it to do rehabilitation work, using it as training and education. And for the future, we're also using it for research purposes. And some of these objective simulations have included either using performance-based assessments or some objective visual analysis or a combination of those tests. And those tests actually have now used repeatable tasks that are reflective of everyday things that we do. And we then time it and then provide some results of that. Some other tests have used indoor and outdoor scenes to recreate the real-life experiences for patients with glaucoma, either looking at their binocular fields and all their driving conditions. However, what all of these tests shows us is that patients with glaucoma actually drove less compared to other people. It also showed us that some of the parameters that we looked at sort of worsens with increasing glaucoma severity. Also, there's indications of activity limitations in these patients. when we also look at that, what the test also tells us that using virtual reality, the difficulties with day-to-day tasks for patients with glaucoma. However, the test has also made it possible for patients themselves to understand their own visual disability. And for us as doctors, it has helped us to better understand the patient perspective and help us improve our patient doctor-patient relationship, as well as how do we optimize the quality of life for our patients. A few other tests has used those virtual reality in real life situations like going to the supermarket, city navigation, and stairs climbing, and all the other tests. And what consistently in all of these tests, whether we're looking at supermarket shopping, or we're looking at stair navigation, or we're looking at city navigation, all of this shows that glaucoma patients require 30% more time to be able to complete these navigations. And that's why we want to be able to do something so that we can reduce this disability that our patients sort of eye into. All of these tests concluded that visual-related disabilities are associated with some lightning conditions and tasks in patients with glaucoma. It also allows us, like I mentioned earlier, to understand our patients' perspectives on how the visual impairments impacts their daily living. It also provides us a different paradigm to look at on how we look at and work with our patients. An integral part of everyday task is wayfinding, which is the process of determining and following a route between an origin and a destination. What we found out is that glaucoma patients perform significantly worse when you're looking at this. And all of that sort of saying that the fact that there's glaucoma, it's affecting the cognitive mapping and therefore affecting the way wayfinding that occurs. Virtual reality also has other functions, and there's a lot of new developments for it in terms of visual fields perimetry. That means just testing for visual fields. You must have heard the talk previously by Dr. Bell that talks about the test in glaucoma. And this is one of the new tests that is coming out, in which case we can use visual reality techniques to do visual fields. The advantage of this method is that it is portable, it is adaptable, it provides an access for marginalized and underserved communities. It also allows for home-based testing and monitoring, and allows us to be able to pick up on things quickly. We've also used it as part of education, and there's a lot of opportunity here for patient education, which is what we're doing with our study this year. The test also shows that not just for glaucoma patients, we can also use to patients that also have a stroke, and we can use this VR technology to do that as well. The study here also shows that, which we all know, that when you have inferior field loss, it's actually much more worse than superior field loss, because when you're walking, you can't see your feet and you can't see what you're walking at, and therefore more risk of collisions. In order for us to prevent all of these problems in our glaucoma patients, the best thing is to actually early diagnose the disease and provide treatments. And the aim of treatment for us is to control the intraocular pressure as a surrogate measurement for treatment. We do say that every millimeter counts, and that means that if I can reduce the pressure by 1 point, I can reduce the risk of worsening by 10%. If we reduce by 5 points, then we can reduce the worsening by 50%. And therefore, as well, the risk of blindness from glaucoma. We do know that with effective treatment, we can reduce vision loss, and our treatment paradigms goes from either we use drops, laser surgery, or other new methods that are present now for glaucoma treatment. However, the main stumbling block in our treatment is the adherence to our glaucoma medications, which is often very poor. We can define adherence or compliance and persistence in different ways. And adherence can just be to the extent to which a person's behavior is in taking the medication, and the compliance is following instructions, and the persistent is that they are able to take their medication constantly and on time. Studies have shown us that 75% of adults skip or miss a dose in the past 12 months. A third of our patients misses doses because they run out of refilling their prescriptions. And about 30% actually fail to fill a prescription on time. And there's different components that we can look at in terms of, is it related to what the patient does or the patient's state of mind or conditions, the therapy, the healthcare system, or the social or economic system that's available. However, to me, I just believe that detecting and treating glaucoma should be equivalent to improving adherence in itself, because I can write all the drops I want in the world, but if it's not being used, then it's not going to work. I think one of the limitations we have is that many patients do not realize the consequences of their actions. We talked about white coat adherence in the sense that we've seen patients that only tends to put on their drops in before they go to a clinic, to an appointment. And once the appointment is over, then that's the end of it. And I think that sort of relates to the fact that they do not understand the consequences of their progression. And what are the facts? We do know that 30 to 80% of our patients do not adhere to the medications. And studies have shown that poor adherence will lead to progression and blindness. 50% of our patients do not follow their medication, and a third of the patients will discontinue their medication within 1 year. That's a lot of data. And will it help us in terms of addressing these issues? And that's some of the discussions we have to have with ourselves. In Canada, 50% of our patients in a study in 2008 shows that 50% do not actually use their medication, or not the way it's prescribed. 26% will miss at least one drop a week, and 4.2% will not use their medications. And we looked at another study also looked at the determinants, and some of these factors were associated with improved adherence, such as using a single dose medications or a fewer medications will help. And this study also shows that the number of missed doses is related to visual field loss. So the more missed doses you have, the more field loss that you have. And what that tells me as well is that if we can improve medication adherence, we can present a path to preservation of our patients' quality of life by preventing the disease from progressing. Even though we do know that glaucoma is always a progressive disease. But there are different steps in looking at adherence. One is that you have to first of all obtain medications. Studies shows that 9% of all medications are never filled. You have to use the medication each day. And studies also shows that only 10% of those prescribed medications were persistent with their medication over the year. You have to time the dose appropriately. And finally, you have to successfully get the drops into the eye, right? So a drop that doesn't get into the eye does not work. So successfully doing that helps. And studies have shown that only 30% of our patients are able to correctly instill an eye drop into the eye. But we do know that life happens. There are sort of different obstacles that could happen. And we can look at it in different ways. And we can sort of say, okay, what can I then do about improving adherence? A lot has been done. So we talked about technological applied changes in terms of smart drop bottles, about automated reminders. We talked about installation aids that have been produced. We talked about improving communication with our patients. And I think that's something we all, as doctors and patients, are working on in terms of helping others go through this disease and reducing the mortality and morbidity from it. We've tried to improve the tolerability of the eye drop medications and even looking at non-medical means of lowering intraocular pressures. And when we do all of that, hopefully we can improve our patient satisfaction. In my institution, we've talked about looking at educational seminars and screenings, and that has helped. Even as much as going to elementary school in the way of looking at a teach the teachers training program that helps the kids to help teach their parents or grandparents about glaucoma control. Another thing that's been suggested is using electronic information. However, a study shows that when you do information via mail or electronic information, it does not improve adherence. And then the question comes in, what else can I do? Some people have tried to use 3D virtual reality to do that. Even though at 3 months, this does not show any improvement. However, there's potential in here in that it may improve adherence in patients at the early stages or who are less affected by the disease. And that's because what we do find out is that when there are no symptoms, like I mentioned earlier, 50% of patients with glaucoma don't know that they have it. So, but when you allow lack of symptoms or limitations, then it's a problem to convince somebody to use their medication rightly. Or if they don't even believe that the vision loss affects them, that's a big thing. And that's some of the dilemma we face at this point in time. However, when we look at the health belief model that sort of focuses on the individual perception of the importance and effectiveness of treatment and their own ability to overcome these challenges, we can then focus more on the patient perceptions and their beliefs by being more engaged. Hopefully, we can reduce all of these numbers that says 50% are skeptical about their vision loss, or 14% do not understand that they are at risk of vision loss. And that's why we do what we do. That's why we propose the study that we're doing right now. And that study basically means, can we use virtual reality applications to simulate eye disease for patients' education? So this is a project that's supported by the Glaucoma Research Society. And thanks to you all for your contributions to the society, we are able to do this. And I will show later on that we're already on our way to doing that. And the objective of our study is to use either 2D or 3D reality to sort of show patients that this is what will happen to you if you don't do anything. And we sort of combine that with looking at all of their imaging, looking at the questionnaires, and sort of assessing their eyes as well. We're able to then apply these VR simulations on patients who do not have glaucoma or patients who have early forms of glaucoma, and show them what their vision loss could be if they do not do something. We're also using this as well for caregivers, so that they can help their relatives to get better and not get into the late stages of glaucoma. We hope that by showing all of these different stages and different simulations, that we can convince people that it is important to do that. So our study will show people what it is like in a grocery store, in a house setting, and doing a driving simulation, both doing for daytime and nighttime driving, navigating a city area over a distance about 90 meters, so that they can actually see what happens when you have no visual loss and when you have visual loss. And hopefully we hope that that may help people come to a better understanding of their own disability. And after that, we'll be able to look at some of the different outcomes that I've sort of talked about previously. So this slide just basically shows what we've done so far. This work is being done with the McMaster University Department of Engineering, as well as the biomedical unit. So here you can see my research assistant, who is also putting on the VR goggle, and these are the navigators that helps to navigate through. The picture on the top right-hand side shows a patient who has glaucoma and who is just navigating through a grocery store. And you can also see the glaucoma monitoring session screen on the computer. And what the system completed is that we can use this printout of the visual fields to actually put in any visual field of any patient that we want. And we can ask another person to simulate that same visual fields, because we can actually make changes within these numbers that are listed up there. So in conclusion, I just want to say that glaucoma has effects on our daily lives and just affects our quality of life. Using virtual reality helps us in better understanding of our own visual disability or the patients themselves. And we can look at new paradigms to improve the quality of life of our patients. No treatment can effectively address glaucoma that has not been diagnosed. We should focus our attention on early diagnosis and initiate treatment as soon as we can. Treating glaucoma without addressing the non-adherence is inefficient for us and ineffective for our patients. Therefore, we need to improve adherence to reduce vision loss in patients without glaucoma. I do hope that one day there's cure for glaucoma, but we can't lose hope. Hope is the first step towards a cure for us for glaucoma. And I want to thank you all for listening and thank the Glaucoma Research Society and all of its supporters for supporting our project. Thank you.
Enitan, thank you very much for that extensive overview on glaucoma, the problems of glaucoma, the problems that patients face, and the issues of using new technology to aid patients understand their disease and perhaps become more involved in their own personal care. I have no doubt that our members and supporters will want to ask you questions. So I do hope you'll stay on and join Dr. Rajiv Bindlish's team, the question and answer panel. This panel generally will take any questions on glaucoma. And of course, any specific questions related to your talk will be directed towards you. So again, many, many thanks and good luck with your research project. And without further ado, I'll hand over to Dr. Rajiv Bindlish and his Q&A panel. Thank you, Rajiv.
Thank you, Graham, for the introduction. Thank you, Enitan. That was a wonderful lecture, very informative. I really enjoyed it. Also, thank you to our supporters for tuning into the annual supporters meeting. Thank you for your support. It is really greatly appreciated. And as you can see, it helps fund projects like Enitan's to help better find, obviously, cures and treatments and better manage glaucoma for our patients. I'd like to introduce the rest of our panel. Enitan, you've already met. Katie Burt, who is up at Sunnybrook Hospital. She's a well-known glaucoma specialist in the Toronto area. I'd also like to congratulate Katie. She's been promoted to full professor at the University of Toronto, and I think that's a great achievement. So congratulations, Katie. And finally, to our new board member, Cindy Hutnick, who's been a glaucoma specialist in Southwestern Ontario and at London in the Ivy Eye Institute. And Cindy is also a full professor of ophthalmology and has done a wonderful amount of research on glaucoma. So welcome to the panel. And so we have 11 questions so far that have come in. A few have been directed to Enitan. And so the first question, Enitan, is do you see a home use for VR in glaucoma patients?
Thanks, Raj. Like I mentioned earlier, there's the role for perimetry, which is for home-based screening. And that's already being used as well anyway, that we can actually use the VR to test the people's visual fields at home. And that sort of helps in terms of you don't have to come to the hospital to have your measurements done. And you can actually do serial measurements over time to actually see whether your disease is progressing. There is a role for that, using it at home.
Okay, thank you, Enitan. So another question for Enitan. Can VR be used to determine if a patient should keep or give up their driver's license?
If we're looking at it in terms of visual field measurement, then you can actually use that to determine whether they're able to drive or not. The studies that have shown the test in people navigating through, driving through obstacles and driving through the city line. It can actually show people if they are able to drive or not by being exposed to that experiment, to that study. One of the things in our study is that we're going to be exposing patients or people who have no visual field defect at all to that experience. We can also have patients who have a different kind of field test or already have some form of glaucoma go through that as well, and they can actually see for themselves whether they're able to drive or not. So it sort of helps the patients in understanding their own condition as well and their own limitations.
Thank you, Enitan. So just to clarify, just for the general population, so we currently do not use VR to actually test you, and we can't use VR to obviously say, hey, you don't meet the requirements to drive. That is a separate, done through the government, and that's got some strict criteria based on your vision and your peripheral vision. However, this is technology that, sometimes patients ask, am I safe to drive? And this might actually educate patients as to whether they are truly safe to drive or not. So I think it's a promising treatment coming up. A question came up through your talk, Enitan, but I'm going to direct this one to Cindy. What do you mean by non-medical means of reducing IOP? What might they be? So Sydney, can you answer that one?
That's a tricky question, and there's a lot of speculation about some other methods that may help. Generally, our only known modifiable risk factor to treat intraocular pressure are the medications and the surgeries. But there are some smaller studies that have suggested maybe some lifestyle changes that could be beneficial. Avoiding certain things tends to be more helpful than adding certain things, but we've all heard about the potential role of marijuana, and I think Dr. Burt has done some excellent research in that area. Staying away from certain things that could elevate your intraocular pressure, such as tight collars around the necks, certain types of exercise. There really hasn't been any scientifically proven way to lower your intraocular pressure consistently other than our standard technologies. But there have been some indirect, non-medicinal, sometimes herbs that have been suggested, but in general, nothing that's really gone through the rigor of what are called prospective multi-center randomized clinical trials and things which have been approved by Health Canada. So whether or not they're safe, you always have to make sure that you run these things by your family doctor, because some of these non-medicinal types of treatments that may be even considered complementary medicine could have some side effects or complications that you may not want. So yes, there are some components of cannabis which may lower your intraocular pressure, but then the recent literature has suggested there may be some components which may elevate your intraocular pressure. So the research is certainly not as rigorous as some of the more standard technologies. But there are lifestyle changes that may be helpful. And the bottom line is there's really no magic way. And at present, the one method that you can depend upon most is by lowering your intraocular pressure through the standard techniques that are recommended by your ophthalmologist.
Thank you, Cindy. Again, another question. There was a lot of questions on VR, Enitan, so you have really sort of piqued the interest of our supporters. Can a glaucoma patient use VR to learn to overcome their deficits of vision and maintain a normal life?
What we do know is that, yeah, what we do know is, sorry. Sorry about that. What we do know is that we can use VR in a way for you to show what's your state of the vision is at this point in time. And you can then see how you can adapt your vision to make you more functional. I talked about changes in the gaze and changes in the eye movement. People have over time adjusted their eye movement and their gaze to be able to use the little vision that they have for them to be a functional member of the society. And that's what the hope that the VR provides for you. And I think that's something that we can look forward to.
Okay, thank you, Enitan.
Did I answer the question? Sorry,
it's a hard question to answer, and I think you've done your best to do that. Here's a question for Katie. How can I limit redness around my eyes from using eye drop medications?
A good question, a fairly common question, and no real sort of magic bullet answer here either. If the redness is too bad, you might need to discuss a change in medication options with your ophthalmologist. Sometimes something can be substituted, which is a little better suited to your skin. Trying to avoid allowing the drops to get onto the skin may be helpful. So dabbing the eyes dry from the outside once the drops go in. You don't want to let tissue soak the drop out of the eye, but you try and keep it off the eyelids and lashes. Sometimes if the skin around is getting a little affected, putting a thin layer of Vaseline on the skin before the eye drop goes in so it doesn't stick on the skin, it'll just roll off, might be helpful. And generally, good health of the eyelids and lash tissue is a good idea. So warm compresses once or twice a day help to improve blood flow to keep the glands in the eyelid working better, so that the quality of the tear film produced by those glands is more normal, and that helps to protect the eye, and also to keep dried up eye drops, dried up tears, mucus and salt crystals from collecting on the eyelids, which then forms an area of irritation and possibly even for infection.
Okay, thank you, Katie. Again, another VR question for Enitan. Do VR simulations show what happens to patients in general, or is it specific to the person using the VR device?
The advantage of the VR is that you can show different situations. So if they don't have any defect, you can show them that they don't have any defect, because then as they navigate through the different scenarios, they will notice that they have no defect. Similarly, if we can also simulate a patient with moderate glaucoma, we can simulate a patient with advanced glaucoma. We can also simulate a patient with a stroke. So anybody who is normal can actually visualize that. Even if you're in the early stages of your disease, we can also show you what you will be like if you stop using your medication and you progress to a severe glaucoma, what your field of vision will be like. So anybody can actually experience that. Even if you've had some defect as well, you can also see that, oh, these are the limitations that you have from those from the advanced glaucoma that you have. So any patient can experience it.
Okay, thank you, Enitan. So I'm going to pose two quick questions to Cindy. One, I hope will just be very quick. Can I use artificial teardrops with glaucoma? And then the second is a question on ginkgo and is it safe to use ginkgo with people with glaucoma?
Okay, thank you. Those are both great questions. And my answer to the artificial tears follows from what Dr. Bird has said. More than 50% of people with glaucoma likely have something called ocular surface disease or dry eye. In fact, there's 4 common things that happen to our eyes as we age, and I think dry eye and an unstable tear film are very common. So yes, you can use artificial tears, but the key is not to use them too close together, because even 2 glaucoma drops that are put in back to back could wash each other out and dilute the effect. There have been research studies that have been shown that it takes a really good 5 minutes for one eye drop to sink in. And if you want the full effect of the second eye drop, to wait 5 minutes later. Even if you space the eye drops out by just 2 minutes, you're already diluting the effect of the first eye drop. So I think the key is, yes, artificial tears are a great idea because many people over the age of 50 have a dry eye, which is uncomfortable. But again, not to space them too close together, that's the key. But otherwise, there's really no contraindication to use an artificial tear with glaucoma. The second question, ginkgo biloba, almost follows from my first answer. It's considered a complementary medicine. It's not really been gone through the same rigor of the scientific trials that many of the approved drugs are. It's a drug that is thought to perhaps increase blood flow and can have side effects of thinning out your blood. So just because something is a complementary medicine, it doesn't necessarily mean it's safer. So you have to make sure you run it by your family doctor. And again, will increased blood flow to the eye help with glaucoma? I think my answer to that question is maybe. Some of the evidence suggests maybe for some patients, but not other patients. Very quickly, there was a recent study that arose from what's called the United Kingdom Biobank. And it was really interesting study that looked at people's DNA, these 23andMe, and found that certain patients which expressed certain genes were more likely to be more sensitive to things like ginkgo biloba or caffeine. So it's really complicated. And in some patients, what may be yes, maybe no. But bottom line, ginkgo may help. Some evidence to support it, but it's not the strongest evidence. Always run it by your family doctor before you start anything.
Okay, thank you, Cindy, for that question. Here's a question for Katie. Are endurance sports such as long distance running or cycling permissible for glaucoma patients?
I'd say generally yes. In advanced glaucoma, we will usually recommend against resistance training, heavy weights, anything that really increases pressure through the body, through the neck, up into the eyes. But cardiovascular training and endurance training may promote ocular health, promote blood flow to the optic nerve, and be in some ways beneficial. I think the value of cardiovascular health overall probably outweighs any possible deleterious effect on the eye. But generally speaking, the overall impression is that aerobic exercise is a good choice.
Okay, thank you, Katie. I'll pose out 2 more questions. One more back to Enitan, which is a little bit of a 2-pronged. So 2 questions. One, could VR replace current visual field tests? And I guess the second question is where do you see the VR technology having its most use in the next 2 to 5 years?
Yeah, thanks, Rick. Those are 2 very nice questions. I think we're already saying that we're using VR technology for perimetry. That's one that's been developed from Toronto, the University of Toronto, that is already being used. And I think there's also some that are also being used as well in other parts of the world. So VR is currently being used for perimetry. And there is the opportunity there for treating, for rehabilitation. So as you also know, there's that study that's been done with patients with retinitis pigmentosa that's using VR technology for rehabilitating those patients. And I think that's an opportunity for us with glaucoma to use for patients with advanced glaucoma and visual field loss or functional loss. I think the opportunity is there, and it has a whole wide of applications that I think in the next 3-5 years, we should be seeing some of it being used in our clinics as well.
Okay, thank you, Enitan. Our last question for the evening, I'll give this to Katie. Is there any promising research being done on repairing a damaged optic nerve as a result of glaucoma?
I think there's a lot of research being done. I'm not sure that anything has got to the stage of being considered quite promising. The large research meetings that I've generally gone to the last couple of years have been, for some reason, a little bit less accessible. So if maybe Cindy, in fact, keeps her finger on the pulse of research very nicely, might know something. But generally speaking, the difficulty of repairing or regrowing an optic nerve is about the same scale as trying to repair or regrow a broken spine or a broken neck. So there'll be, if progress in one field might easily lead to progress in ours, but I don't think it's anything that's going to be practical within the short term, and sadly, possibly not even during the balance of our careers. Cindy, just very quickly.
Yeah, my little plug here is that's exactly why we have the Glaucoma Research Society of Canada. I know some of the grants that have been funded are actually looking at translational studies where they're looking at nerve tissue in the laboratory and testing strategies that may improve the function. So yes, Katie's right. Nothing maybe tomorrow that will be here, but there's a lot of studies suggesting that it may be possible one day. And this is exactly why we need the support to support additional research that will help us unlock some of those mysteries.
Okay, thank you, Katie and Cindy. We're going to wrap it up. There were just a couple of other quick questions, which I'll just kind of address as a housekeeping. Yes, the presentation for this evening has been recorded. It will be posted on our website, and a link will be shared with you, and you can then in turn share this with your families. Enitan, you piqued a lot of interest with VR, and I mean, there's still about 3 or 4 VR questions here. Congratulations. It was a great presentation, a great study. To people out there with your questions, in terms of wanting to be a volunteer, ask your ophthalmologist if he can put you in touch with somebody if you'd like to volunteer. I mean, VR is a realm of the future, and it will be shared with patients, educators, hopefully soon, hopefully when it becomes a little bit more real time. And it may take a little bit of learning. If you have an interest in VR out there, hopefully if you have some kids who use the Sony PlayStation or Xbox, maybe they can share their VR unit with you, and you can get a little bit of a taste of what VR is all about. Okay, so we're going to wrap up the question and answer. Thanks to our panel, and thank you to the participants for sending in the questions. And until next year, and you can always send in your questions, and hopefully I will do a good job at answering them through our website. Thank you, everybody.
Thanks, Raj.
Good night.
So thanks, Raj, for chairing that very interesting session, and thanks to all of the other panelists. I'd like to take this opportunity before we sign off to present a certificate of recognition to Dr. Sogbesan. I add my congratulations on a very informative session. Should just comment, I'm currently undergoing a test for home visual field, so I'm a little familiar with the contraption you put over your head, and I'm optimistic that that may lead to something more interesting in the future. So that concludes the formal part of the meeting. As I mentioned at the beginning, we hope that we can convene in person next year. And on that note, I just wish all of you who joined us the rest of a good evening for the rest of what's left of it. And thank you once again for taking the time to join our meeting and hopefully learn something about what we do, why we sponsor this research, and you were able to see some of the direct results. So on that note, thank you very much, and we'll look forward to seeing you again next year.